But we're gonna kind of read through this and then we're gonna apply it and do problems together. All right, so Ireland, can you read for us the intro up there on top?
Sure. Arterial blood gas analysis is an essential part of diagnosing and managing a patient's oxygenation status and acid-base balance. The usefulness of the diagnostic tool is dependent on being able to correctly interpret the results. This self-learning packet will examine the components of an arterial blood gas and what each component represents and interpret these values in order to determine the patient's condition and treatment.
Okay, good. Peyton, can you read overview?
The pH is a measurement of the acidity or alkalinity of the blood. It is inversely proportional to the number of hydrogen ions in the blood. The more H plus present, the lower the pH will be. Likewise, the fewer H plus present, the higher the pH will be. The pH of a solution is measured on a scale from 1 very acidic to 14 very alkalotic.
Yep.
Alkalotic. A liquid with a pH of 7, such as water, is neutral, neither acidic nor alkalotic.
Okay, now, they have something in here that's actually a little bit incorrect. What do they have in here that's incorrect? 0 to 14, not 1 to 14. So can you guys fix that? I don't know why they have it like that, but probably because they're thinking it from a human perspective, that if anybody's pH was 0, they'd be like, 100 miles underground, basically. But the pH goes from 0 to 14. Okay, Lucy, can you read the next paragraph?
Sure. The normal blood pH range is 7.35 to 7.45. In order for normal metabolism to take place, the body must maintain this narrow range at all times. When the pH is below 7.35, the blood is said to be acidic. Changes in body system functions that occur in an acidic state include a decrease in the force of cardiac contractions, a decrease in the vascular response to catecholamines, and a diminished response to the effects and actions of certain medications. When the pH is above 7.45, the blood is said to be alkalotic. An alkalotic state interferes with tissue oxygenation and normal neurological and muscular functioning. Significant changes in blood pH above 7.8 or below 6.8 will interfere with cellular functioning and, if uncorrected, will lead to death. So how is the body able to self-regulate acid-base balance in order to maintain pH within the normal range? It is accomplished using delicate buffer mechanisms between the respiratory and renal systems. Let's examine each system separately.
Okay, Renee, can you read?
The respiratory buffer response. A normal byproduct of cellular metabolism is carbon dioxide. CO2 is carried in the blood to the lungs where excess CO2 combines with water to form carbonic acid. The blood pH will change according to the level of carbonic acid present. This triggers the lungs to either increase or decrease the rate and depth of ventilation until the appropriate amount of CO2 has been reestablished. Activation of the lungs to compensate for an imbalance starts to occur within 1 to 3 minutes.
Okay, let's go back a second and underline something important in there. I would underline that the blood pH will change according to the level of carbonic acid present. Some of this you guys already know. We talked about this, right? So if you have too much carbonic acid, your pH would have been decreased very severely, right? The more carbonic acid you have, the pH goes down. So that's going to make your lungs go faster, right? Try and get rid of that carbon dioxide. Okay. All right, flip over. Fiona, can you read the renal buffer response?
The renal buffer response. In an effort to maintain the pH of the blood within its normal range, the kidneys excrete or retain bicarbonate. As the blood pH decreases, the kidneys will compensate by retaining bicarbonate, and as the pH rises, the kidneys excrete bicarbonate through the urine. Although the kidneys provide an excellent means of regulating acid-base balance, the system may take from hours to days to correct the imbalance. When the respiratory and renal systems are working together, they are able to keep the blood pH balanced by maintaining 1 part acid to 20 parts base.
Okay, does everybody understand that? How it's working? We've got two systems working together to maintain your pH. Your respiratory system as well as your renal. And the renal is talking about the kidneys, okay? So your kidneys, what this said is that basically if you need to get rid of bicarbonate, you can pee more of it out. And if you don't need to get rid of so much bicarbonate, then your kidneys hang on to it. Make sense?
Yep.
Okay. Now we're gonna get into disorders. Ovi, can you read respiratory acidosis?
Just call me Obi.
Oh my gosh, I'm sorry. Katie, sorry.
Respiratory acidosis is defined as pH less than 7.35 with a PaCO2 greater than 45 millimeters mercury.
Right.
Acidosis is caused by an accumulation of CO2 which combines with water in the body to produce carbonic acid, thus lowering the pH of the blood. Any condition that results in the hypoventilation can cause respiratory acidosis. These conditions include central nervous system depression related to head injury, central nervous system depression related to medications such as narcotics, sedatives, or anesthesia. Impaired respiratory muscle function related to spinal cord injury, neuromuscular diseases, or neuromuscular blocking drugs. Pulmonary disorders such as atelectasis, pneumonia, pneumothorax, pulmonary edema, or bronchial obstruction. Massive pulmonary embolus, hypoventilation due to pain, chest wall injury, deformity, or abdominal distension. The signs and symptoms of respiratory acidosis are centered within the pulmonary, nervous, and cardiovascular systems. Pulmonary systems include
Dyspnea?
respiratory distress, and or shallow respiration. Nervous system manifestations include headache, restlessness, and confusion. If CO2 levels become extremely high, drowsiness and unresponsiveness may be noted. Cardiovascular systems include tachycardia and dysrhythmias.
Here, pause there. What does tachycardia mean? Is your heart rate too fast or too slow? Too fast. Tachycardia is too fast. All right, and dysrhythmia means it's not beating in a normal sinus rhythm. You would have some sort of alternate rhythm. Okay, keep going.
Increasing ventilation will correct respiratory acidosis. The method for achieving this will vary with the cause of hypoventilation. If the patient is unstable, manual ventilation with a bag valve mask is indicated until the underlying problem can be addressed. After stabilization, rapidly resolvable causes are addressed immediately. Causes that can be treated rapidly include pneumothorax, pain, and CNS depression related to the medications. If the cause cannot be rapidly solved, the patient may require mechanical ventilation while treatment is rendered. Although patients with hypoventilation often require supplemental oxygen, it is important to remember that oxygen alone will not correct the problem.
Okay, I would underline that last point. Oxygen alone will not correct the problem. And when they're talking about requiring mechanical ventilation, they're talking about putting a patient on a ventilator, on a machine that is artificially controlling their breathing. Okay? All right, good. Flip over. Teresa, respiratory alkalosis.
Respiratory alkalosis is defined as a pH greater than 7.45 with a PaCO2 less than 85 millimeters
Mercury.
mercury.
Mhm.
Any condition that causes hyperventilation can result in respiratory alkalosis. These conditions include psychological responses such as anxiety and fear, pain, increased metabolic demand such as fever, sepsis, pregnancy, or thyrotoxicosis.
Good. Thyrotoxicosis.
Medications such as respiratory stimulants, central nervous system lesions. Signs and symptoms of respiratory alkalosis are largely associated with the nervous and cardiovascular systems. Nervous system alterations include lightheadedness, numbness and tingling, confusion, inability to concentrate, and blurred vision. Cardiac symptoms include dysrhythmias and palpitations. Additionally, the patient may experience dry mouth, diaphoresis, and tetanic spasms of the arms and legs. Treatment of respiratory alkalosis centers on resolving the underlying problem. Patients presenting with respiratory alkalosis may have dramatically increased work of breathing and must be monitored closely for respiratory muscle fatigue. When the respiratory muscles become exhausted, acute respiratory failure may ensue.
Okay, so there are a ton of things in here, term-wise. Let's go back to the beginning and make sure we understand all these terms. So, increased metabolic demands, what are they talking about with that? What process it needs to be happening at a very high rate? Cellular respiration. Okay. Fever is fever. Sepsis is, what does sepsis mean? If you're septic, you have a massive infection. Right, very good. Thyrotoxicosis is a problem with your thyroid, which your thyroid is very closely linked with your metabolism, so that's common to metabolism. What else do they have in here? Dysrhythmia, we said before, means not normal heart rhythm, right? Palpitations is like if you felt, you guys have probably had this at some point, where you like literally feel your chest like pounding. You can feel your heart beating, kind of like too strong, that's a palpitation. Diaphoresis is sweating. So, like sometimes with people, if they're about to pass out, they completely start bringing on like a sweat, that's diaphoresis, they become very diaphoretic. Any other term you guys didn't know in there?
Tetanic.
Tetanic means a tetany, like rigid, like contractions, like that. Okay, good. Laura, can you do metabolic acidosis?
Metabolic acidosis is defined as a bicarbonate level of less than 22,
22, just, it's fine.
22 with a pH of less than 7.35.
Mhm.
Metabolic acidosis is caused by either a deficit of base in the bloodstream or an excess of acids other than CO2.
Good, everybody underline that sentence.
Diarrhea and intestinal fistulas
Fistulas.
may cause decreased levels of base. Causes of increased acids include renal failure, diabetic ketoacidosis, anaerobic metabolism, starvation, salicylate intoxication. Symptoms of metabolic acidosis center around the central nervous system, cardiovascular, pulmonary, and GI systems. Nervous system manifestations include headache, confusion, and restlessness, progressing to lethargy and stupor or coma. Cardiac dysrhythmias are common, and
Kussmaul.
respirations occur in an effort to compensate for the pH by blowing off more CO2. Warm flush skin as well as nausea and vomiting are commonly noted. As with most acid-based imbalances, the treatment of metabolic acidosis is dependent upon the cause.
Underline that.
The presence of metabolic acidosis should spur a search for hypoxic tissue somewhere in the body. Hypoxemia can lead to anaerobic metabolism system-wide, but hypoxia of any tissue bed will produce metabolic acids as a result of anaerobic metabolism, even if the PaO2 is normal. The only appropriate way to treat the source of acidosis is to restore tissue perfusion to the hypoxic tissues. Other causes of metabolic acidosis should be considered after the possibility of tissue hypoxia has been addressed.
Okay, good, so back to the first paragraph. Intestinal fistulas, a fistula is an opening, okay? So an intestinal fistula would be like, openings in your intestines where they shouldn't be combining with one another. So you guys know the digestive system, right, how there's different pHs in different parts of the intestine, so small intestine, large intestine. You can have fistulas between like large intestine and small intestine, and you've got different pHs mixing together. So anything like that is a fistula. Renal failure would be kidney failure. Diabetic ketoacidosis, so that is a very dangerous kind of end stage of diabetes, or a condition that can occur in diabetes where they start basically breaking down protein and excreting ketones in their urine. And you guys know what ketones are back from like chapter 1. Do you remember? A ketone is a carbonyl group. Remember? That is in the middle of a molecule, the key is in the middle of the lock, so C double bond into an O in the middle. They start excreting ketones in their urine, which is a problem because that causes further kidney damage. Anaerobic metabolism, so in terms of humans, this would be considered lactic acid, right, metabolism. And then salicylate is a medication, like aspirin, intoxication. I think everything else. Anything else in that? Vocab-wise, I think we're good, okay.
Hypoxic tissue.
Oh, hypoxic tissue is tissue that is not, bless you, that is not getting enough oxygen. Hypoxia means not enough oxygen.
And then also, Kussmaul.
Oh, Kussmaul, where was it? In the first paragraph. Okay, Kussmaul breathing is, so if you see somebody, typically if they have metabolic acidosis, they're like, it's a very severe condition, and they look like this. They're trying to blow off all that CO2. So if you see somebody like doing that characteristic type of breathing, that's called Kussmaul respiration. Okay, good. Flip over. All right, one more, and then we're gonna apply it. We got metabolic alkalosis. Let's have Jeremy round this off. For his birthday week.
Metabolic alkalosis is defined as a bicarbonate level greater than 26 something per liter with a pH greater than 7.45. Either an excess of base or loss of acid within the body can cause metabolic alkalosis. Excess base occurs from ingestion of antacids, excess use of bicarbonate, or use of lactate in dialysis.
Okay, everybody underline that.
Loss of acids can occur secondary to protracted vomiting, gastric suction, hypochloremia, excess administration of diuretics, or high levels of aldosterone.
Good, underline that sentence too.
Symptoms of metabolic alkalosis are mainly neurological and musculoskeletal. Neurological symptoms include dizziness, lethargy, disorientation, seizures, and coma. Musculoskeletal symptoms include weakness, muscle twitching, muscle cramps, and tetany. The patient may also experience nausea, vomiting, and respiratory depression. Metabolic alkalosis is one of the most difficult acid-base imbalances to treat. Bicarbonate excretion through the kidneys can be stimulated with drugs such as acetazolamide,
Acetazolamide.
but resolution of the imbalance will be slow. In severe cases, IV administration of acids may be used. It is significant to note that metabolic alkalosis in hospitalized patients is usually iatrogenic in nature.
Good, okay, iatrogenic means unknown. You guys learned like 1,000 new vocab words this morning, right? Okay, anything else in there that you guys did not know?
What does tetany mean?
Tetany again is like if your muscles like are.
Oh, yeah.
Like that. Anything else?
What exactly are they saying in the last sentence? When
In the last sentence, they're saying that if you have a patient in the hospital that you determine
You
has
wouldn't know.
metabolic alkalosis, they usually finding the exact cause of it is extremely hard.
oh, okay.
Yeah.
Gastric suction.
Gastric suction. Okay, so gastric suction is when people come in and they are vomiting out of control, what you do is you take a big tube, it's about the size, it's a little bit bigger than your finger, I'd say, and you go down their nose, it's really pleasant to put in, and you go all the way down their nose into their stomach, and you let it sit there. And on the end of the tube, there are holes all around, okay, and it's also open on the end. And you hook that up then, coming out of their body to a suction machine, and you turn up the suction, so it's providing constant suction coming out of their stomach. Now, you can dial up the suction, but it's kind of like a low suction, so that anything that's being produced in their stomach is immediately being sucked out. But the problem with sucking stuff out of your stomach is what else is in your stomach? Acid. So if you keep sucking, all that acid out of the body, then you can end up with metabolic alkalosis. Yeah. Okay, anything else in there? Yeah. Hypochloremia means low chloride levels.
Okay.
Good? Okay, flip over. Now, here are the components of an arterial blood gas. So all of those things are conditions. How you test for them is you do a very painful test, and you have to take it from the patient, okay? And so what happens is, the typical place you do this is right here in your radial artery. You take a big needle about this long, okay? It's exceptionally painful. It's probably one of the most painful things you can have happen. It's different than an IV, all right? So very, very different. I'm talking about how you get this. I'm just like, what are you talking about?
Sorry.
I'm talking about how you would get this arterial blood gas. Okay?
Okay.
So what you have to do is you have to like feel for the radial artery pulse, which you can feel in your arm. It's kind of like right above your bone in your wrist. Okay. If you feel it, can you feel your pulse? Do you feel with these two fingers? Don't feel with your thumb. Feel with those two fingers. You can feel your pulse. Okay. Now what you do is so you cock their hand back just slightly. You take this big old needle and you shove it in, and the idea is you're blindly doing this. It is a real art because you can't see where you're going. You have to aim for that pulse, but you obviously can't hit your finger. So you feel where the pulse is, and then you insert the needle, and as you're inserting the needle, you're pulling your fingers away so you're not sticking yourself. And then once you got that needle in there, then what happens is on the outside of the needle there's what's called a catheter. It's a little plastic tube. And so once you get it in there, you get a flash of blood back. All right, now it's an artery, so it's pulling back under very high pressure. So you get a big flash of red blood. And then what you do is you insert this catheter, it's like a straw, basically, into the artery, and you let it sit there, okay? And obviously, if you left that uncapped, you would bleed to death. All right, so it's very, very, somewhat dangerous procedure. You take the needle out, now you've got a hose, basically, right? A straw sitting in their artery, okay? And you have several options. You can either, if you're just doing this like real quick, like in the emergency room, they just want to figure out what these values are, you can just take a syringe and suck off some blood and then take it out. But when you take that out, if you don't put a lot of pressure on there, they will bleed out. So you have to really push a lot of pressure on there for a long period of time until you have the whole clotting cascade that we talked about yesterday or whenever that was, okay? Or in patients that are in the hospital and you want to take frequent samples, you don't want to keep doing that to them. Like, it's very painful. So you can leave the hose in, you put a little stopcock on it, a little valve, and you close it, and you hook it up to a pressure bag that provides equal pressure to what's in the artery so that blood doesn't rush out. And then anytime you need blood, you just walk into the patient's room, you open up the faucet, you take some blood, you close the faucet, and you leave. But you gotta be very careful because it could also, like, in patients that are out of it, that are sedated, that are intubated, that kind of thing, if you don't have it hooked up right, they can bleed to death, so you have to be very, very careful. So that's that. Okay, so now, they do not numb anybody when they do it, no. They sometimes numb babies, but, you know, honestly, the whole numbing thing, it isn't really, yeah.
Have you ever had to do it?
Yeah. This is something that is pretty dangerous, so typically doctors only do this, but like the difference between being like a nurse in an ICU and being like another kind of nurse, those are some of the kinds of things that you learn how to do and that you get to do. So yeah, it's very nerve-wracking. Okay, and the worst part is if you miss and you have to keep going. Yeah. Okay, so anyway, on that note, that's our Friday of blood story. Components of the arterial blood gas. So you take off blood, and now what you do is you send it to the lab and you look for all these different things. These are the parameters that you're measuring. You're measuring the pH. You guys already know the pH is normal, so circle that. You need to know the normal range. PaO2, that's the partial pressure of oxygen that is dissolved in arterial blood. So again, partial pressure means the amount of the blood, if we're talking about PaO2, it's the amount of pressure of oxygen in the blood compared to every other gas in the blood. So the normal range of oxygen, partial pressure in the blood, in arterial blood, is 70 to 80 millimeters of mercury. Okay, now, saturation is different than partial pressure, and we're going to go over that on Monday with a graph that you definitely need to know, having to do with the Bohr shift, okay? But saturation of arterial oxygen, that means how much of your hemoglobin is basically full of oxygen, is 95 to 100%.
Is that the same as a blood ox? Like those little things that.
Pulse ox, yes, pulse ox, yes, that's what it's sensing. Yep.
So you said the normal range of partial pressure was 70 to 80?
80 to 100. Did I say it wrong? I meant, sorry, 80 to 100, yeah. And then PaCO2, the amount of carbon dioxide partial pressure is 35 to 45. Does it make sense to you that you would have a higher partial pressure of oxygen in arterial blood than carbon dioxide? Yes, because where is that artery coming from? Your heart. And where has it just gone? The lung. So it should be higher in oxygen, right? Okay. Then bicarbonate, you know, is HCO3, actually I should say minus there, HCO3 minus. The normal range of bicarbonate in your bloodstream is 22 to 26. And then at the bottom, BE stands for base excess, okay? That is telling you either the amount of too much or insufficiency of the amount of bicarbonate. And it's a range, it's either -2 to +2. If it's a -2, it's telling you your bicarbonate is deficient, you don't have enough of it. And if you have more, if you have a +2 base excess, it's telling you that you have too much bicarbonate. Yeah, Alex?
Do you want us to remember the normal ranges of all of these?
I do
or
want you to.
just pH?
Yeah,
All
so
of them?
you should already know pH, you
Yeah.
guys know that one, right? PaO2,
Mhm.
you should know. SaO2 is very easy, that's almost, it should be basically 100%, okay? And the other three, yeah, you should know, okay? All right, flip over. So now, here's how we analyze it. So underline what you need as we kind of go through this, and then we're going to go through some case studies. Okay, steps to our arterial blood gas interpretation. The arterial blood gas is used to evaluate both acid-base balance and oxygenation, each representing separate conditions. Acid-base evaluations requires a focus on 3 of the reported components. So these are the main 3 things you're looking at: pH, PaCO2, and bicarbonate. So here's how you logically kind of go through this analysis. Step 1, first thing you look at is the pH. And you determine, is the blood within a normal range, which would be what? Okay, 7.35 to 7.45, or is it alkalotic, which would mean it's greater than 7.45, or is it acidotic, which would be less 7.35. Okay, step 2. If the blood is alkalotic or acidotic, you have a problem. And now you got to say, what is causing the problem? And your choices are respiratory or metabolic. So how you start by looking at that is you start looking at the PaCO2. Remember that with a respiratory problem, as the pH decreases below 7.35, the PaCO2 should rise. That's very important. If the pH rises above 7.45, the PaCO2 should fall. So you're going to compare the pH and the PaCO2. If the pH and the PaCO2 are moving in opposite directions, very important, then the problem is mainly respiratory. And if it's mainly respiratory, then you can take measures to correct it, because you know the problem is in the respiratory system, okay? Step 3, you're gonna look at the bicarbonate value. Recall that with a metabolic problem, normally as the pH increases, the bicarbonate should also increase. Likewise, as the pH decreases, so should the bicarbonate. So you're gonna compare the two values. Important, if they are moving in the same direction, then the problem is primarily metabolic in nature. And by metabolic, they're referring to what? What system? Not lungs, but what's the other system that controls this whole thing? Kidneys, renal. Okay, so renal is, they're talking about metabolic. All right, so that chart down there on the bottom is very, very important. So let's go through it again. Respiratory acidosis, does that make sense that your pH would be down with that? Yes. Okay, if you have respiratory acidosis, the problem is respiratory, it's a respiratory problem. So you would have a PaCO2 that is higher, okay, and your bicarbonate would be normal. Does it make sense that if you had respiratory alkalosis, your pH would be high? Yep, and if you're blowing off all of your CO2, does it make sense that your PaCO2 in your blood would be lower? Yeah, and again, your bicarbonate is normal. Whereas metabolic acidosis, we know that the pH would be low, has nothing to do with your CO2, but you have metabolic acidosis because you don't have enough bicarbonate. Does that make sense? Okay, and then metabolic alkalosis, pH is high, and bicarbonate is high. Yeah?
Is it possible to have both respiratory and metabolic?
Yes. There are mixed, these are like, I'm teaching you like the very, very basic things. There are mixed things, there are things that are like pages long of like interpretation. Yeah, this is like the easiest of the Sudoku puzzles, and then there are like books and books and books on how to do this. Okay, flip over. Example 1, Jane Doe. So they call any patient that comes into the emergency room who is unresponsive. If it's a girl, it's Jane Doe, and if it's a guy, it's John Doe. All right, so Jane Doe is a 45-year-old. You guys underline what you need to as we go through this. Admitted to a nursing unit with severe asthma attack. That's all we know. She's been experiencing increased shortness of breath. Okay, you can put above that SOB. That's the medical kind of SOB. Shortness of breath. Since admission 3 hours ago, I just want to make sure if I put it on the test, you're not thinking I'm like, crazy or something. Okay. Man, she's in a mood today. All right. Her arterial blood gas result is as follows. All right. So they took an arterial blood gas and this is what they got. By the way, they have the date on there and they have 1843 because everything in medicine is military time. So what time is 1843? 6:43 at night. Okay. So the pH is 7.22. Is that low or high? Low. So draw an arrow next to it that goes down. PaCO2 is 55. Low or high? High. So draw an arrow going up. Bicarbonate is 25. Bicarbonate is perfect, right? 22 to 26. So that's across there, right? Just draw a straight line. All right. So follow the steps. We assess the pH. pH is low. Does that make sense? So this patient is acidotic, right? Do we know, is it respiratory or metabolic? Well, how are we going to do that? We're going to look at the PaCO2. The PaCO2 we said is high. So it's in the opposite direction of the pH, and the bicarbonate is within the normal range. So, down at the bottom. Acidosis, we would say this is respiratory acidosis. How do we cure this patient? What is her problem, by the way? What is her problem? What do we know about her when she came in? Severe asthma. So, why does she have respiratory acidosis? She can't get enough O2 in, but more importantly, she can't get her CO2 out. That's her problem. So how do we fix that? Well, we got to improve her ventilation status. So we could get her oxygen. We could put oxygen on her, and that would help. We could put her on a ventilator and control her breathing, and that's kind of fun because you can dial her up and make her blow more air off than she's taken in. So that's kind of fun. You can, what's your problem? You see, let me fix your problem. Pulmonary toilet. That sounds really weird. Pulmonary toilet means you basically squirt different chemicals down their airway. Typically they're on a ventilator when you're doing this and they're sedated. But there's different chemicals that can kind of, or medications that can kind of help facilitate getting rid of that carbon dioxide. Or by administering bronchodilators. What does that do to your bronchi? Open them up. Then why do your bronchi? the better your gas
Is
exchange.
that like a medicine you would take? That would
Yeah,
be
like an
better?
inhaler, like if you don't have anybody that's asthmatic, they take like a albuterol inhaler or something like that, that's a bronchodilator. Okay, flip over, example 2. Oh, now we got John Doe. All right, John Doe is a 55-year-old admitted to your nursing unit with recurring bowel obstruction. What's his deal? He's got a traffic jam in his bowels. Not good. Yes. He has been experiencing intractable vomiting, meaning he cannot stop vomiting, for the last several hours, despite the use of antiemetics. Those are medications that make you not vomit.
That sucks.
Yeah, so he's basically puking. Here is his arterial blood gas, and now we're stabbing him with a big needle. I'm sure he appreciates that. Okay. pH is 7.5, high or low? High, so draw a little arrow next to it. PaCO2 of 42. Normal, so draw, sideways arrow next to it. Okay. Bicarbonate of 33. High. All right, so is he acidotic or alkalotic? Alkalotic. What's his deal? Metabolic. Why has he got metabolic alkalosis? Because he's been puking his guts out. He's been puking up all his acid, right? So how do we fix him?
Give him some acid.
Hook him up with some acid. Well, perhaps. But first we might want to try less drastic measures, Jeremy. Which might include giving him IV fluids, right? Giving him IV fluids, and also we might give him medications to reduce his base excess. And if that doesn't work, then they did say under severe conditions you would give acid, but that has a whole host of other things. Okay.
How would they get rid of the bowel
Obstruction surgery. Really his only
So, because it would keep it, like,
It would
if you
keep-
did all that,
Right.
then you have to.
Right.
Would he keep on vomiting under anesthesia?
No.
Okay.
You can knock, that's a really good question. You can knock out that entire sensory nervous system.
Okay,
Yeah.
it's just like what he's.
That'd be really unfortunate. Yeah. Okay, now we're gonna go into a little bit harder one, so those are pretty easy for you guys. Okay, so Renee, read for us about compensation, since you asked about the more complicated ones. Here you go.
Thus far, we have looked at simple arterial blood gas values without any evidence of compensation occurring. Now see what happens when an acid-base imbalance exists over a period of time. When a patient develops an acid-base imbalance, the body attempts to compensate. Remember that the lungs and the kidneys are the primary buffer response systems in the body. The body tries to overcome either respiratory or metabolic dysfunction in an attempt to return the pH into the normal range. A patient can be uncompensated, partially compensated, or fully compensated. When an acid-base disorder is either uncompensated or partially compensated, the pH remains outside the normal range.
Okay, underline that, that's important.
In fully compensated states, the pH is returned to within the normal range, although the other values may still be abnormal.
Underline that.
Be aware that neither system has the ability to overcompensate. In our first two examples, the patients were uncompensated. In both cases, the pH was outside of the normal range. The primary source of the acid-base imbalance was readily identified, but the compensatory buffering system values remained in the normal range. Now let's look at arterial blood gas results when there is evidence of partial compensation. In order to look for evidence of partial compensation, review the following 3 steps. 1. Assess the pH. This step remains the same and allows us to determine if an acidotic or alkalotic state exists. 2. Assess the PaCO2. In an uncompensated state, we have already seen that the pH and PaCO2 move in opposite directions when indicating that the primary problem is respiratory. But what if the pH and PaCO2 are moving in the same direction? That is not what we would expect to see happen. We would then conclude that the primary problem is metabolic. In this case, the decreasing PaCO2 indicates that the lungs, acting as a buffer response, are attempting to correct the pH back into its normal range by decreasing the PaCO2, blowing off the excess CO2. If evidence of compensation is present but the pH has not yet been corrected to within its normal range, this would be described as a metabolic disorder with a partial respiratory compensation.
Okay, pause there. Does that make sense to everybody? Does everybody understand that?
When it says like compensation, what is it?
It means your body's trying to like compensate, it's trying to like make up for the problem, it's trying to adjust back to homeostasis. Make sense to everybody? Okay, Renee, finish up.
3. Assess the HCO3. In our original uncompensated examples, the pH and HCO3 move in the same direction, indicating that the primary problem was metabolic. But what if our results show the pH and HCO3 moving in opposite directions? That is not what we would expect to see. We would conclude that the primary acid-base disorder is respiratory and that the kidneys, again, acting as a buffer response system, are compensating by retaining HCO3, ultimately attempting to return the pH back to the normal. back towards the normal range. The following tables on the next page demonstrate the relationships between the pH, PaCO2, and HCO3 in partially and fully compensated soils.
Okay, so the next page is very important, I'm not gonna read through all that, but we're gonna use that as a reference, okay? That basically is what Renee just completely went through. So kind of leave it open so we can kind of compare, we're gonna go through another couple of examples. Okay, John Doe is admitted to the hospital, example 3. He is a kidney dialysis patient. Underline that. What does dialysis mean? Right, he can't filter his own waste products, right? So he's hooked up externally to filter his blood to be returned to his body because his kidneys are not working well enough.
How often do you have to do that?
We're gonna do that unit coming up, but basically it depends on what's going on with your body. There are some people who need to be on continuous kidney dialysis, 24 hours a day. There are people that have different kinds of dialysis they're walking around the school with, like there's even kids in school with this, and there's like a bag they can wear, and they like open it, they let the dialysis like kind of run, and then they close it every couple of hours. There's people that go in for blood dialysis, there's a lot of different types of it. Okay, so he's got kidney dialysis, who has missed his last 2 appointments at the dialysis center. Uh-oh. So basically, he's got waste products up to the wazoo in his body. All right, his arterial blood gas values are as follows. pH, 7.32, high or low? Low, so draw an arrow going down. PaCO2, 32,
Low.
low. Bicarbonate, 18, low. All right, so what do we have? Acidosis or alkalosis? Acidosis. Okay, let's look at step number 2. We're looking at the PaCO2. It is low. Normally, we would expect the pH and the PaCO2 to move in opposite directions. But this is not the case. Because the pH and PaCO2 are moving in the same directions, it tells us that the acid-base disorder is primarily metabolic. Why does that make sense with what we know about him? Where's his problem? His kidneys don't work, so it makes sense that he's got a metabolic problem, right? Okay, so whenever you're like coming up with solutions for these things, make sure it makes sense with what's going on with the patient. If you know they have renal disease, it's probably a renal problem, right? If they have a weird blood gas. Okay. What do we do for him? How do we help him?
Dialysis.
Take him to dialysis. Go pick him up. All right, good. Flip over. Next one. Jane Doe. Jane Doe is a patient with chronic COPD, which stands for, I want you to write it above there. Yes, who said that? Very good. Chronic. How did you build it? Disorder and disease, everyone. Okay, so it's a problem of the lungs. Okay, he's admitted with a chronic COPD, being admitted for surgery. Oh, Jane Doe. Her admission lab work reveals an arterial blood gas with the following values. pH is 7.35, is that high or low? No. Ah, good. PaCO2 of 48. High. Bicarbonate 28. High. All right. So, what is her deal? What is her deal? Dr. Jeremy, what's her deal?
Respiratory acidosis.
Well, you would think, is she compensated or uncompensated?
Slightly compensated.
Yeah, I would actually say she's very compensated.
Very.
So I would say fully compensated
Fully
respiratory acidosis. Make sense to everybody? Okay, flip over. John Doe, the trauma patient. Uh-oh. With altered mental status. These are people that come in that are just like flailing out of their mind and trying to whack you when they're coming in. They just are not in the right place. They've been screwed up somehow. His initial arterial blood gas result is as follows. pH is 7.33, high or low? Okay. PaCO2 of 62. Holy lordy. All right, bicarbonate of 35. High. All right, now, is he acidotic or alkalotic? Acidotic. Okay, so if the PaCO2 is high, normally we would expect the problem to be respiratory, right? However, we've got the bicarbonate is also high. So his deal, down in number 3, he is partial.
Give him base.
Give him base, look him up with some base. It sounds to me like he's been hit in the head. Okay, so he probably needs to go get a CAT scan and then maybe even have surgery on his brain to release some of the pressure on his brain. That's probably what's causing his issue. All right, last example. Jane Doe is a 54-year-old female admitted for an ileus. An ileus is when you stop having peristalsis through your intestines. You have a frozen intestine.
That sounds painful.
It sounds very painful. Just start wiggling for her. She's been experiencing nausea and vomiting, poor thing. An NG tube, that's the tube I was telling you about before, nasogastric tube. It goes down the nose and into the tummy. Has been in place for the last 24 hours. Here are the last ABG results. pH is 7.43. Normal. Oh, she got something good going on. PaCO2 of 48. High. Bicarbonate of 36. All right, so her pH is normal. Okay, but what is her deal? We've got an NG tube down into her stomach, constantly sucking. So what do you think is happening? A metabolic problem, and what is she doing to compensate for that? She's compensating with her respiratory system. So that is a fully compensated metabolic alkalosis. How do we fix her? She's got an ileus.
Medication.
Either medication or probably surgery, depending on what's going on. Okay, good. Let's talk about this graph on the next page, and then we will stop there. You guys did a good job with this. Okay, this graph is exceptionally important. You must be able to draw it, interpret it, act it out, whatever you want to do with it. Okay, it is called the oxyhemoglobin dissociation curve. It is a tool that shows the relationship between oxygen saturation and partial pressure of oxygen. So look down at the graph. On the y-axis, we've got the saturation of oxygen. All right, now I want to just say something about that because this is kind of a very hard concept to understand. In your blood, you have red blood cells, correct?
Yes.
On your red blood cells, you have hemoglobin. Let's pretend this is a hemoglobin on my red blood cell. This whole thing is a red blood cell, okay? Hemoglobin. Hemoglobin is the protein that carries oxygen. Hemoglobin, you know all about the primary, secondary, tertiary, quaternary, etc. Hemoglobin can carry 4 molecules of oxygen. If it's carrying 4 molecules of oxygen, it is 100% saturated, okay? If it's carrying 3, it's 75, if it's carrying 2, it's 50, if it's carrying 0, it's 0. Does that make sense? If every red blood cell, every hemoglobin is carrying 4, you have 100% saturation. So look at this graph. The saturation of oxygen at 100% would be like what I just drew, okay? Down at the PaO2, basically, what you can do is you pick one number. So do you guys see how they have the dotted line drawn there at 60? If we're looking at 60 millimeters of partial pressure of oxygen, okay, they would tell you which one to look at. They've got lines A, B, and C, all right? So what they're showing you is that under different conditions on this graph, if this, let's say, is normal, you can have hemoglobin holding on to oxygen more tightly, and in that case you shift up. Or you can have hemoglobin giving up the oxygen more freely, and in that case it shifts down.
So you don't want them to hold on more?
It depends on what's going on with your body, okay? If your tissues, if your cells have a higher metabolic demand for oxygen, if you're running, your tissues are like, give me oxygen, what do you want your hemoglobin to do? You want your hemoglobin to be less saturated because you want to give it up to the tissues, okay?
Oh.
But under conditions where your metabolic demand is not as high, you don't need to give it up to your tissues, and in that case, you want your
So
hemoglobin to
it's kind of
stay.
implied that the low saturation is due to like it already gave the oxygen?
Yes,
Okay.
yes. So there's different conditions that either shift up or shift down the ability for hemoglobin to give or receive oxygen, okay? And we'll go through this more on Monday, but this middle situation is kind of just how normal things are. If you're walking around, things are going well. If you have a blood gas where your pH goes down, if you become acidotic, what do you want to give to your tissues? Oxygen. So which way would you want to shift this, up or down?
Down.
Down. Good. Okay? If your pH goes up and you become alkalotic, what do you want to do with your hemoglobin? You wanna shift up, right? Because you don't need to give as much to your tissues, you can hold on to it yourself, okay? Temperature, if your temperature goes up, what does that do to your metabolic demand? Up. If your temperature goes up, do you want your hemoglobin to give more or hold on to more? Give more. So in that case, it's gonna become less saturated. Make sense? So there's all sorts of different conditions that can cause either a shift up or a shift down. Now the other thing is, when you're studying this weekend, realize that when they're talking about a shift up, that is called a shift to the left. And when you shift down, that's called a shift to the right. All right. So that is hard to wrap your head around. That's a very complex topic. Okay, so go through it this weekend, and then Monday, what we're going to spend the majority of Monday in is kind of going through these graphs and figuring out some more of them. Okay?